I'm B.F. Graham, founder of the Princeton Propellers, and on behalf of the Princeton Area Alumni Association and Quadrangle Club, welcome to tonight's program on stereotactic radiosurgery, a transformation in managing neurologic disease from operating room to outpatient treatment. I am coming to you from our Battlefield Parkside studios in Princeton, New Jersey, USA, and tonight's speaker, Naveed Rajal, MD, Director of Neurosurgical Oncology at Capitol Health's Institute for Neurosciences, is coming to us from his office in nearby Hopewell Township. He is here to discuss advances in managing neurologic disease and the underlying technical innovations which have made these advances possible. And now it's time to introduce our speaker, neurosurgeon Naveed Rajal, who for the past 2 decades has been involved in significant translational brain cancer research, clinical patient care, and neuro-oncology clinical trials at the highest levels. Following undergraduate studies at UCLA, where he earned degrees in both neuroscience and computer science, our speaker spent the next 5 years in the Harvard-MIT Health Sciences and Technology Society program at Harvard Medical School. Over the next 4 years, from 2011 to 2015, Dr. Rajal completed a neurosurgery residency at the Massachusetts General Hospital. In 2015, he returned to California to be attending neurosurgeon at Kaiser Permanente, where he also focused on neuro-oncology and advanced participation in brain cancer clinical trials. In 2017, Capitol Health brought him to New Jersey to be Director of Neurosurgical Oncology at their Institute for Neurosciences. In addition to caring for patients, Dr. Rajal continues to conduct translational research in targeted local therapies for brain cancer, publishes widely in medical journals devoted to neurosurgery and cancer research, works with the Congress of Neurologic Surgeons to develop treatment guidelines, and leads the weekly neuro-oncology multidisciplinary tumor board at Capitol Health's Cancer Center. He is a fellow of the American Association of Neurological Surgeons and a member of the Congress of Neurological Surgeons and the Society for Neuro-Oncology. We're delighted that he can be with the Princeton Propellers tonight. And with that, I will turn the floor over to Dr. Naveed Rajal.
All right, thank you, BFG. I appreciate the introduction. Thank you all for being here. I think we've been trying to get this talk, since about 2 years ago prior to COVID. So I'm glad we can, at least do it via the Zoom form. But this is something that many people don't know, that stereotactic radiosurgery really has revolutionized how we treat neurologic disease, especially cancer. Majority of stereotactic radiosurgery is treated as an outpatient. You don't need to be admitted to the hospital, and it's something that certain types of neurologic disease it's completely revolutionized how we treat it. We really can't, talk about stereotactic radiosurgery and advancements in the treatment of neurologic disease without really talking about advances in the technology and science in relationship to neuroscience. There's really been an exponential growth of the ability to obtain real detailed imaging, and that then allows for precise targeting of neurologic pathology. So what I was trying to show you guys before is these are kind of a history of imaging and how basically advanced it's become. This is a skull X-ray, which you really can't see anything in terms of the brain. And then this is a CT scan from 1971. You can see how grainy it was. It's hard to delineate any specific structures. And then you move to kind of, a better scan, higher resolution CT scans that are done now. And then, these are MRI scans. So this is an MRI scan that now shows deep, structures within the brain, the thalamus, and now we can, target these areas. Here, this picture that's very colorful shows, diffuse tensor imaging, which shows tracks in the brain. And, by doing this, it helps us really target specific lesions and minimize, harm and morbidity. And then, functional MRI has really been able to allow us to really assess where certain areas of the brain are responsible for certain functions. And this field has just been advancing exponentially. So with all this data, it's very difficult as a human being to kind of, process it. But at the same time as our data has been increasing exponentially, our processing speed has been being to analyze this with artificial intelligence, things like that. A famous, inventor in computer science talks about the exponential growth of computing, such that with all this data, we're able to kind of have improved ability to kind of process this data, and with the exponential growth in computing also. So that's kind of the background, which allows us to kind of get to talking about what stereotactic radiosurgery is and how we use it now to really target specific lesions in the brain. So just to start with some basics. So what is radiation therapy? So at the most basic form, the concept is ionizing radiation causes DNA damage, and that can cause cell death, inhibition, and growth. So when you talk about kind of conventional radiation, where the brain and, like for instance, the tumor gets radiated, normal cells have the ability, they have DNA repair capacity ability that's much stronger than tumor cells. Are kind of erratic and dysfunctional. So they're usually able to kind of repair their ability to have ionizing radiation. But radiosurgery is a little different. It's a much higher dose, and you can actually, it's an ablative technology. We'll get more into that. But I just kind of want to kind of go through the basics of radiation. So, when we talk about the radiation that we use for stereotactic radiosurgeries, we're talking about, X-rays and gamma rays, which are higher energy photons, and also proton beam. But basically, these are just very high energy photons that cause that DNA damage, and which allows for, cells to die. So before I start talking about stereotactic radiosurgery, we really have to talk about conventional radiation therapy that most people think of when you think about radiation. And it's really important to understand that they're very different in terms of the technology and the concept of how to specifically treat a specific target. So conventional radiation therapy, it talks about referring to like repeated small doses of radiation. And for instance, with whole brain radiation, over 6 weeks, the brain gets radiated. And the concept is you give little doses, the cancer cells will die, but the normal cells won't be as affected. But we know that even with fractionation of radiation, giving in small different doses, normal tissues that have turnover are affected, especially things like memory and things like that. But the concept is really fractionate the dose, and for instance, with whole brain radiation, you give little tiny doses of 1.8 to 2 gray with the cumulative doses of 60 grays. But so we're talking about a good 30 days of coming in and getting radiation with the potential of radiation to normal brain. So here, kind of at the most basic form, what's the difference between radiation therapy and radiosurgery? So radiation therapy, you're trying to treat this target here, this little circle, with a dose of, let's say, 2 gray. So you give a dose to the whole kind of object of 2 gray. And the normal area, let's say the normal brain gets that dose, but also, that target area gets that dose. Now, stereotactic radiosurgery is different in that there's non-parallel beams, and you basically target a specific area to get the highest dose, converging, for instance, you could get a high dose of 8 gray here with minimizing the total radiation to the surrounding structure. So this is a very kind of basic concept, but when you think about it 3-dimensionally, it really does make a difference. So that's at its basic. So how does it work? The concept is it delivers a really high dose of radiation in a single, or sometimes we even fractionate it, to 2 or 3 or 5 treatments in order to kind of get a really hot dose to the site we want to hit with minimizing radiation to the rest of the brain. And this really happens because there's a progressive, quick decline in the radiation outside of the treatment target. The big differences, for instance, with something like treatment for cancer in the brain, which we used to always do whole brain radiation. We would assume someone had metastatic cancer to the brain. We would assume their whole brain is full of tumor, and patients would get whole brain radiation therapy. But we know that that causes long-term cognitive issues. And not only that, many tumors, for instance, like melanoma and renal cell carcinoma, they're radio resistant. So if you even give these little doses to the tumors, they don't really aren't affected. So, unfortunately, a patient ends up getting all this dose and, the tumor continues to go. But stereotactic radiosurgery, I'm going to kind of refer to it as SRS, is as effective to these tumors because you can give a really high dose. And what happens is, those radio resistant tumors, basically are ablated. They're killed with the high dose of radiosurgery. So, this is really kind of evident with the story of Jimmy Carter. Jimmy Carter kind of got diagnosed with metastatic melanoma to the brain when he was at the age of 88. And you can see here's a scan of someone with metastatic melanoma, and you have these little kind of tumors here, you have a tumor here, you have a tumor here. Now, in the past, if you had widespread metastatic melanoma that went to the brain, the area of where we didn't have radiosurgery or immunotherapy, patients had a 3-month survival. But now with, combining stereotactic radiosurgery in combination with some of these newer medications like immunotherapy, you can see that Jimmy Carter's, now 97, 98 years old, and, he's functioning well, even though he got diagnosed with this bad disease. So it's really kind of changed the way we treat patients. He never had surgery, and you can see in this patient here, these lesions were treated with radiosurgery, and they kind of just disappear. So it's really kind of revolutionized how we think of even patients and their long-term prognosis and their survival. And again, I'll go through some cases of my own where you really can make a significant difference even if the patients can't get surgery. So one of the biggest things that is very well documented is conventional radiation therapy has much worse neurocognitive dysfunction compared to stereotactic radiosurgery. And basically, the concept is you're getting a minimal dose to any other structure in the brain. And that's why patients who get stereotactic radiosurgery do so much better. So patients always ask, like, why can't all tumors, why can't you do stereotactic radiosurgery to every single tumor? And honestly, as the time and technology has gone on, we're treating more and more even bigger tumors with stereotactic radiosurgery. But if you sometimes give a large dose for a tumor that's greater than 4 centimeters, it can really sometimes cause some edema and potential toxicity from a lot of vasogenic edema. But as time has moved on, technology's progressed. This is actually changing. It used to be less than 3 centimeters. Now it's even less than 4 centimeters. So our guidelines are changing, and the outcomes long-term we've seen with the, improved technology is even better and better. So the field of stereotactic radiosurgery it's multiple different technologies, and you guys might have heard these kind of different terms. So kind of probably the most common ones that are talked about are Cyberknife radiosurgery. So this is based on X-ray radiation, but the X-ray radiation source is actually in the robot head. And it's an image-guided robotics system. And we're going to talk a lot about this. This is something I use, almost every week, once or twice a week. And I could talk to you about in detail this technology. And I'll kind of go more into this. There's gamma knife radiosurgery. So gamma knife radiosurgery is based on gamma rays. And it has to do, and we'll get into it about, different isocenters of radiation. So these kind of centers all kind of add up and they conform to a specific shape that you want to treat. But that technology is based on gamma rays. And then there's proton beam radiosurgery, and these are charged protons versus the photon radiation of the above. Now, I'll quickly talk about proton beam radiosurgery. It does have its benefits, and I'll kind of go into this. So protons have this concept of a Bragg peak. So the dose that goes in basically a certain depth has basically a dose percentage that goes up really rapidly and drops off very quickly. So it minimizes the exit dose. So for instance, here's a picture here on this side of a patient who's trying to get radiation to their spine. Now photons, let's say if you're treating in this direction, they get an exit dose. Protons don't have an exit dose. They have basically a dose at a certain depth that has the maximum radiation dose, and then it falls off. So again, protons, the benefit is there's no exit dose, but the limitation is protons, they're not as conformal to beams. So it's hard to kind of really, your entrance dose might be higher. You're sometimes limited by the ability to conform the beam to a certain structure, but that technology is improving significantly. So that's, I'm going to get more into, Cyberknife radiosurgery, and I want to kind of get a little bit more into detail into that. So here just is the basic concept. So this is a robot, and the actual linear accelerator is in the robot head. So the concept is you could collimate the beams through the robot head, and the beams move. The robot moves, and this way you can get multiple non-parallel beams, minimizing the total radiation dose. And we'll kind of get more into that. Here's kind of how it's set up, such that the robot on the fly changes the way it moves based on patient movement too. So I'm going to show a video. I'm going to come back to the screen, and then I'll kind of explain more about how Cyberknife radiosurgery works. So here's just the introduction screen. It has audio. I'll let it go through so you guys can hear about it.
Better understand how the Cyberknife robotic radiosurgery system is used to treat tumors and other lesions in the head. We believe that the more a patient and their family and friends know about the steps involved in the Cyberknife treatment, the more comfortable everyone will be with the procedure.
So they're trying to get into this is an outpatient treatment.
One of the most advanced stereotactic radiosurgery systems in use today. It relies on robotics and sophisticated image guidance technologies to attack tumors with extreme precision. The flexibility of the robotic arm enables your doctor to deliver multiple beams of high-dose radiation directly to your tumor from almost any angle, while minimizing damage to surrounding healthy tissue and critical structures.
So that and those angles is, again, advancements in technology that have allowed us to do this.
Your treatment involves a team approach in which several specialists participate. Once the team is in place, you will begin preparation for the Cyberknife treatment.
So just real quick before I let the video continue. So Cyberknife radiosurgery was developed by a neurosurgeon out in Stanford, but radiosurgery usually is a team approach with a radiation oncologist and a neurosurgeon working together in terms of planning, but also as part of the treatment plan, there's a physicist, there's radiation therapists, there's dosimetrists, there's a big team of people who are part of the initial treatment planning.
Unlike other radiosurgery systems, such as the gamma knife,
so in the olden days, in order to really fix the patient's head, they used to put these frames in, and this is kind of an older way to treat gamma knife, is you would have to fix the head in a frame. With Cyberknife, you don't need to do that, and they'll kind of go into why.
Does not require patients to be fitted with a rigid and invasive head frame. As a result, you will be more comfortable while your radiation is delivered.
So this is a mask that's made form fit to the patient prior to treatment, and so the mask when it's warmed up is kind of mobile, and then when it's at room temperature, it form fits to your face, and they obtain a CT scan with the mask on. So the mask prevents gross movements, but it doesn't prevent small tiny movements, and those small tiny movements actually the robot adjusts to tiny movements based on these perpendicular x-rays that are done during the procedure. And again, I'll show you that on the next screen, but I'll continue with the video so you guys can see how it's treatment occurs. So that's the mask.
A flexible mesh mask will be created and custom fitted to your face. Your radiation therapist typically performs this step. This comfortable and non-invasive mask will be used to stabilize your head and neck during treatment. While wearing the face mask, you will undergo a CT scan. This CT data will be used by the Cyberknife team to determine the exact size, shape, and location of your tumor. An MRI, PET scan, or angiogram also may be necessary to fully visualize the tumor and nearby anatomy. Once the imaging is done, your face mask will be removed and it will be stored in a safe place for use in your Cyberknife treatment. During treatment planning, your relevant CT, MRI, or PET scan data will be downloaded into the Cyberknife system's treatment planning software. Your medical team will determine the size of the area being targeted by radiation, the radiation dose, and will identify critical structures where radiation should be minimized. After your treatment plan is developed, you will return to the Cyberknife Center for treatment.
So usually the scan is done, the planning is done, the physicist kind of runs the plan through the machine, and we make sure everything is within constraints, which means that you want to make sure certain areas of the brain don't get too much radiation, the optic nerves, etc. And then, patients are, asked to come back, and, this is kind of a day of treatment where they, walk in as an outpatient.
Over several days. Typically, treatments are completed within 5 days. For most patients, the Cyberknife treatment is a completely pain-free experience. You can dress comfortably in street clothes, and your center may allow you to bring music to listen to during the treatment. When it's time for your treatment, you will lie down on the treatment table while your custom-fitted face mask is secured into place. The Cyberknife system's computer-controlled robot will slowly move around your body to various locations, from which it will deliver radiation to your tumor. You can expect each treatment session to last 30 to 90 minutes, depending on your specific tumor. Nothing will be required of you during the treatment, except to relax and lie as still as possible. After completing your Cyberknife radiosurgery treatment, it is important to schedule and attend any follow-up appointments. You must keep in mind that your tumor will not suddenly disappear. Once treatment is complete, most patients quickly return to their daily routines with little interruption to their normal activities. If your treatment is being delivered in stages, you will need to return for additional treatments over the...
You can see he made all his basketball shots after that too. So the concept that they're trying to emphasize here is that this is outpatient. We have patients who come in between their lunchtime at work, they get treated and they go home. You don't feel anything. And it's, pain-free. So, I mean, that's what they're trying to emphasize with that kind of clip there. But again, to kind of go back in terms of now that you guys seen how the robot moves and that patient wears the mask, but one of the main things that, which is the significant advancement based on technology and processing speed, is there's these perpendicular x-rays that are taken of the patient, every, depending on how critical the structure is, maybe every 45 seconds, every 30 seconds. These x-rays are kind of orthogonal x-rays. That information goes into the system. If there's even a millimeter or, we talk about even 0.7 millimeter of movement with the patient with the mask on. The mask is for the purpose of the mask is for gross movements. The robot on the fly will adjust based on the plan if the patient moves even by a small, small millimeter movement. That's the kind of the biggest advancement in technology that's allowed us to do that. It really requires an immediate kind of processing speed. So, the lady in the video mentioned 30 to 90 minute treatments. As that processing speed has improved significantly. The treatment times are getting shorter and shorter. Again, with as technology gets better and better, it's just going to get more precise, and the treatment times are going to be more faster. So here's an example of a treatment plan. Okay, so again, it really has to do with how good our imaging is. So the more precise your imaging is, the more precise of a target you have, and then you can also really, for instance, let's say this is a tumor that's near the hearing nerve. It's called the vestibular schwannoma. We're treating the tumor. We want a high dose kind of right where the tumor is, and then we're able to, prior to this, actually treatment, based on the plan that we develop with the physicists, exactly know how much dose the surrounding tissue is. And this structure here is the brainstem, and we want to make sure the brainstem doesn't get more than the constraint dose that we have. And this is an idea, with the kind of simplified version, is the beams, you can have over 150 beams coming in different directions, this way minimizing the entrance dose and just maximizing the dose that the tumor is being focal. The beams also, because of how you guys saw the robot moves, they can conform to any type of structure. It doesn't have to be a circular structure. And this is, again, one of the benefits of the Cyberknife treatment. So again, the accuracy of stereotactic radiosurgery depends on the resolution of the treatment plan. And with that scan from 1971, you can't develop a treatment plan. As imaging has gotten better and better, we're able to really kind of isolate small spots in the brain and treat them. The real-time registration that I talked about, on the fly, the robot is adjusting based on the x-rays during the radiograph. That really determines the precision. And that, again, it's really one of the big advancements that's been allowed based on improvement in processing speed. And again, the pointing accuracy of the robot, that's also extremely important. So we talk about the Cyberknife having, and this is actually a little old, but 0.7 millimeter precision. It's getting better and better as technology gets better and better. So this is a quick picture just to show you. Everyone goes, "Oh, how do you know what dose the optic pathway could get, the cochlea could give?" Over many years, they've basically kind of got certain threshold maximum doses that these areas can get without having significant side effects. These are really low doses. So what our physicist does is they're able to basically tell us exactly the optic pathway gets this dose, the cochlea gets this dose, and we could say, well, I don't want the cochlea to get that much of a dose, so he'll move the beam in a certain way. So we know every structure, how much the dose is getting. And this, again, it always depends on how great the technology is in terms of identifying those structures via imaging. So what do we use stereotactic radiosurgery for? And this is kind of the second part of the talk, where you guys learned about the technology, and now we'll talk about all the different neurologic disease this has been able to treat. So radiosurgery for metastatic brain cancer, radiosurgery for locally aggressive brain and skull-based tumors. These are kind of deep tumors within the brain, such as pituitary tumors, deep meningiomas, tumors along the hearing nerve. Radiosurgery for neurovascular pathologies. There's things called arteriovenous malformations. Radiosurgery has really changed the way we treat these tumors, these vascular lesions that have the tendency to bleed. Really, it's kind of changed how we treat, spinal tumors. Before you would have to do some really aggressive surgery with a lot of morbidity. Now you could combine, surgery with radiosurgery, or you could just do radiosurgery on its own. And then this is kind of the most exciting field, is functional radiosurgery. So treatment of trigeminal neuralgia, which is a very kind of very difficult facial pain that you get, really ruins patients' lives. But you could treat this non-invasive with stereotactic radiosurgery. You could treatment for essential tremor. There's a lot of data that's shown that radiosurgery does a thalamotomy, which I'll get into. And now it's kind of the exciting stuff is people are starting to treat, psychiatric diseases such as OCD with radiosurgery. So I'm going to kind of quickly hit on each one of those. So I talked about all these exciting things, but I got to talk to you about the limitations and some things that we sometimes see with radiosurgery, although it keeps getting better and better and it's limited. you can get what's called radiation necrosis. Here's a picture of a tumor that was treated with radiosurgery. And sometimes you get aggressive swelling surrounding the tumor. Basically, as the tumor dies, it causes a lot of inflammation. This is really just treated with steroids, but this is something that we see. You could get significant swelling sometimes from these. But really, it's just treated with steroids and is self-limited. The concept of delayed secondary radiation-induced tumors is extremely rare. People talking about it at about 0.7%. At 10 years, it's really rare. So here's like a little vascular lesion that was treated with radiosurgery. It was ablated. And then, 10 years later, there was a little tiny meningioma that developed. So, but that is extremely rare, but we do talk about that. And these days, I really don't even mention it to patients because the risk of it is so low, but we do actually mention it when we do treat patients. So getting back to uses of stereotactic radiosurgery for metastatic brain disease, this is not something novel. These are guidelines. These are national guidelines from American Society of Radiation Oncology. That stereotactic radiosurgery is part of the guidelines. In the past, we used to do whole brain radiation, but I show you this slide that based on like the initial presentation, single brain metastasis or multiple brain metastasis, you can see SRS is part of the treatment modality that is basically accepted. And actually, if it's not done, some people talk about it being, not standard of care now. So, it's really important that, whoever gets treated, they definitely should be at a center that they do stereotactic radiosurgery, because if not, then you're probably not getting the standard care treatment. And the most kind of important thing that we talked about, Jimmy Carter's case, is there's a lot of tumors that are radio resistant, such as melanoma, renal cell carcinoma, some type of non-small cell lung cancers, and sarcomas. So these are the type of tumors that conventional radiation didn't work on. And in the past, if you had these tumors, we would say, oh, the radiation is not going to work. We have to rely on, chemotherapy. But we know there's great data that radiosurgery works really well with these types of tumors. Here's a specific case, one of my own cases. This is a 50-year-old patient who had metastatic renal cell carcinoma to his brain stem. So here's the brain, here's the brain stem. This is right in the middle of his brain stem, and he also has a tumor in his cerebellum. This type of tumor, if you found this without stereotactic radiosurgery, you can't really do surgery into the brainstem without causing significant dysfunction, because you have to go through normal brain to get to it. And conventional radiation wouldn't work on a tumor like this. So radiosurgery has allowed us to tell these patients that no, it's, you have a potential for survival more than a month and 3 months. It doesn't matter that your tumor is right in the middle of your brainstem. So we treated this patient outpatient. He just kind of walked in. He had some mild weakness in terms of symptoms. And 3 months later, you could see, with stereotactic radiosurgery, the tumors are gone. Again, the patient was fine, and he lived for more than two and a half years until his systemic cancer took him over. Not his cancer that went to his brain; it was the renal cell cancer in his body. So again, this is a great example of that. Here's an elderly female, in late 80s. She was, I think, she was 88 years old. She had metastatic breast cancer. And she had a lot of medical problems, and she could see she has these 2 tumors with a lot of swelling in her brain. Now, in the past, if you showed up at the age of 88 with these types of tumors, and you couldn't undergo surgery, this is basically, we talk about, going to hospice. There's really nothing we can do. But, this patient, we started her on steroids. Her swelling became better, and we treated her outpatient with radiosurgery. She's 3 years out, and she's doing great. And you could see that you can't even see, a tumor or the swelling that was there in prior imaging. So here's where stereotactic radiosurgery really has made a difference in patients' quality of life, is the treatment of skull-based tumors. These are tumors that are kind of near the brainstem, near, very important nerves, that surgery always leads to, significant, at least short-term dysfunction. There's a tumor that's very common called the vestibular schwannoma or acoustic neuroma. This is a tumor along your hearing nerve. So it's a tumor that's along the covering of the hearing nerve. So it grows along the hearing nerve. Unfortunately, the hearing nerve is basically right near the facial nerve. So when we used to try to do surgeries for these small tumors, there's a high risk of facial nerve paralysis in addition to completely losing your hearing as we try to take these tumors out. But with stereotactic radiosurgery, you shoot these tumors with radiation, and patients do great. It's outpatient. They don't need a long ICU stay for surgery. And here's just a bunch of different studies that microsurgery versus SRS. Patients do so much better in terms of their quality of life with stereotactic radiosurgery. In the past, people would say, okay, you're treating the tumor along the hearing nerve with radiation. Isn't it more likely for you to lose hearing after you treat with radiation compared to surgery? And that's been proven false. With radiosurgery, you could still, I always tell patients 1/3 of patients will have improvement of hearing, 1/3 is about the same, and 1/3 will decline, which is pretty much equivalent to actual surgery. And you don't have all the side effects associated with surgery. So this is a type of deep tumor along the skull base that's pushing on the brainstem that really has completely changed the way we treat. 20 years ago, 20, 30 years ago, we really talk about mostly doing surgery, but nowadays, it's very infrequent that we even talk about doing surgery for these tumors. We usually, radiosurgery is kind of first-line therapy, especially for small tumors like this. So here's a tumor, it's kind of orangey. This is kind of where the pituitary gland sits, right at the bottom of the skull base. This is a tumor known as a craniopharyngioma. It grows from the skull base, grows into the brain, and it's right kind of in one of the most important locations in the brain. It pushes on the eye nerves here. It pushes on a lot of different cranial nerves that are coming out, that are important. And these are extremely difficult tumors to do surgery on because they are doing surgery on it. They're attached to so many important structures. There's a potential of kind of really causing the patient to have problems. So there's good data that quality of life is much more important than taking a big tumor out and making the patient blind and losing their pituitary function. And as radiosurgery has advanced, we basically kind of have a combined approach to these treatment of these tumors. So here's like the pituitary tumor. This is this is a neuroanatomy picture. It's hard to see, but the point of this picture is for you guys to understand that the pituitary tumors, they kind of sit here like a craniopharyngioma, and there's all these important structures surrounding it. Here's the carotid arteries as they go into the brain. Along this area, there's these important nerves that control your eye movement, your facial. Here's the, basically the optic nerve and the optic chiasm. There's all these important arteries. There's the pituitary stalk. So a picture like this, it's affecting all these structures. And if you're aggressive with surgery, you can basically cause damage to any of those structures. You could cause injury to optic nerves. You could cause injury to the pituitary gland, the vascular structures. You could have leakage of cerebrospinal fluid. So, so what if they've looked at, what if you, instead of being aggressive, which is GTR, is called gross total resection, what if you just do subtotal resection and just radiate these patients with radiosurgery? And in these cases, the patients had similar survival, in some cases, even better survival. And overall, what's more important, it's not living longer, it's making sure your quality of life is improved. So patients who have aggressive resection of tumors, they get issues with their pituitary gland, and almost 100% of patients develop what's called diabetes insipidus. They lose function that's basically responsible for retaining water in the body, and they have to be on medications. And a lot of patients, they lose complete function of their pituitary gland. So what we've started to do is we start to do combined procedure where we debulk the tumor, we minimize the compression of the tumor, and then we treat the rest with fractionated radiosurgery. So here's an example of kind of a tumor kind of down there where it was debulked and then it recurred, and then they treat it with radiosurgery. And patients, the question always is, oh, the nerve is getting optic nerve is getting a lot of dose, the pituitary gland is giving a lot of dose. But we know from long-term data that for instance, in these patients, in this study specifically, that only 91% of the patients achieved control of tumors, and they really didn't have any visual or neuroendocrine complications related to treatment. So always, the optic nerve is one of the most sensitive structures, to radiation, but with advances in technology and being able to really delineate the nerve when we do these treatments, you can minimize the dose the nerve gives, especially when you treat with these non-parallel beams that are coming in. And for example, the critique always from radiosurgery is, oh, well, if you don't do surgery, your nerve's going to get a lot of dose and you'll lose vision. But when they do long-term studies, here's a long-term study that they treated lesions right near the optic nerve, and for the majority of patients, even at long-term follow-up, they had improvement with only a few percentage of them having worsening in their vision. So that again is one of these myths associated with radiation that was true for radiation, but not really for radiosurgery. And then again, the pituitary gland is right there. What's the likelihood of losing your pituitary function with treating with radiosurgery? And again, in this study here, only a few patients out of 74 patients developed hypopituitarism. So that again is a concept that's more for conventional radiation. With stereotactic radiosurgery, you can literally contour out where the pituitary gland is and make sure it doesn't get a significant dose, minimizing the risk for long-term side effects. So here's a patient that I had. He was a 45-year-old male. He was really healthy. He used to do CrossFit, and he had a very blurred vision, headache. He lost his acuity in his left eye. He had this calcified mass kind of pushing on his optic nerve chiasm. So he had this kind of lesion here. It was kind of calcified, and this is the pituitary stalk. So if you mess with this during surgery, you'll lose your function of some of your pituitary gland. You can develop what's called diabetes insipidus. So our plan going into this surgery was to debulk it, minimize its compression on the optic nerve with subsequent radiosurgery. So going into a surgery like this, wherever you're going to be, with center, whatever center someone's getting treated, they have to be able to have the competency that there are multiple tools to treat something like this, and without having those tools of surgery, radiosurgery, then you potentially can lead to worse outcomes. So this patient, we had a multidisciplinary discussion. It looked like there was invasion into the pituitary stalk, and the consensus was to decompress, which we did. His vision started to get improved, and we treated the patient with the Cyberknife to the residual tumor. And post-op, this patient's been doing great. I followed him for, it's almost 4 years now, and his vision's completely back to normal function. He has no endocrine dysfunction, and he's doing really well. So this is, again, one of those things that's really changed the way we treat these patients. So for a lot of pituitary tumors, radiosurgery has changed the way we treat it. Some people have something what's called Cushing's disease. They get these little tiny tumors in the pituitary gland. It wreaks havoc on the body. In the past, they're always difficult to resect. So, these days, they might have an initial surgery. In the past, you would have 1 surgery, 2 surgeries, 3 surgeries. They end up taking out the whole pituitary gland. But now, because our imaging is so good and detailed, you could pick up this little tiny spot in the gland and you could target it with radiosurgery, and, patients do well. There's a disease called acromegaly, and this is a growth hormone secreting tumor. And these are very difficult to treat tumors. Again, radiosurgery has kind of, again, changed the way we treat these tumors. So very, things that were extremely difficult to treat, cause significant morbidity, have changed based on radiosurgery. So really quick, treatment of neurovascular pathology. There's these things called arteriovenous malformations. They're basically these kind of big tangles of blood vessels in the brain. It's like shunting of an artery straight to a vein. And these can lead to a hemorrhage, sometimes catastrophic hemorrhage in the brain. So these are usually attached to some very important arteries in the brain, and there's a lot of morbidity with trying to do surgery to take it out, or trying to go via endovascular approach and embolize them. But what's amazing is if you treat these tumors with radiosurgery, just kind of over 5 fractions, there's great data that, like, for instance, this big kind of hypervascular mass, you treat it, outpatient with radiosurgery, it kind of dissipates over time. And the concept is you basically take those kind of that nidus that's causing the tumor, and you basically radiate it. And over time, it kind of, there's hyperperforation of the intima, and it kind of collapsed on its own safely over many years. And patients don't need a big, potentially complicated surgery. So this is just, there's just so much data. This is not something that's new, but long-term data shows that these are just all this outcomes of obliteration of these large arterial venous malformations. Here's like a potential plan. This is a volume. Sometimes you treat a small volume of the vascular malformation. As it gets smaller, you come back and you treat another volume. Again, these type of plans that are conform to these kind of strange shapes. This is not a round shape. You can only do with using radiosurgery to kind of conform to these areas. And then now also things like dural arteriovenous malformations are also treated with stereotactic radiosurgery too. So stereotactic radiosurgery for spinal tumors. So here is a big spinal tumor. You could see it's kind of eating away the bone, and what you need to do a lot of times you need to separate the tumor away from the spinal cord. Sometimes it's tough to really drop the dose for radiosurgery, right? If the tumor is really pushing on the spinal cord. So instead of doing some huge surgery trying to take the whole tumor out, you could do a smaller surgery, instrument the patient, make sure they're stable, and then you could develop a very kind of complex plan. Here on the bottom screen, the left-hand corner of this figure E, is a plan that you could conform the radiation specifically to the residual tumor and minimize the radiation to the spinal cord. So these are, this concept of what's called separation surgery has been allowed via radiosurgery. So if we didn't have that ability, then you really couldn't target that tumor, and sometimes you would end up doing these aggressive surgeries, and patients wouldn't do well from the surgery. So this is again, another something that's kind of changed treatment modalities. Now in combination treatments, doing kyphoplastic with radiosurgery, sometimes you have a tumor that erodes the bone and collapses the bone. So instead of doing some big surgery to take that tumor out, what you do is you could do kind of, again, an outpatient procedure, which is a kyphoplasty. You put some cement in the bone in order to strengthen the bone, and then you radiate the tumor. Again, it's something that really, especially for older patients who can't tolerate big surgeries, really has changed the way we treat these patients. And now people are combining it with some of these new targeted therapeutic agents like tyrosine kinase inhibitors, immunotherapy, and we're seeing a lot of benefit from combining some of these newer therapies with radiosurgery, similar to metastatic melanoma and immunotherapy. So here's kind of the really exciting phase of radiosurgery and imaging, and in neuroscience, neurosurgery is for the treatment of functional disorders. So things that are very difficult to treat, and in prior terms, they required surgery, but now with stereotactic radiosurgery, you could treat it outpatient. We could target really tiny spots. The best data for some of this, and the most long-term data, is for the treatment of trigeminal neuralgia. So trigeminal neuralgia is these like really bad spasms you get in your face along the distribution of the trigeminal nerve. And usually the primary treatment is with medication, but if patients can't get relief from medications, you could treat the nerve with doing a special type of surgery that requires an ICU stay. It's called the microvascular decompression. Or you can, outpatient treat the nerve with stereotactic radiosurgery. So here is like a plan. Here's kind of the brainstem, and here's a nerve kind of coming out. This is the trigeminal nerve. And the goal is to treat this small kind of 5 to 6 millimeter area. You want to kind of really give a high dose to this spot. And you can see this is an axial plane, this is an coronal plane. But you want to minimize the dose to the brainstem and kind of all these other important structures in the way. So radiosurgery really has allowed us to do this. So you want to give a very high dose and kind of ablate this. This is different than treatment of a tumor. This is a really high dose to really kind of quiet down the cells and somewhat ablate the nerve. So this is really this, as our ability to image and our details of our image get better and better, we are able to out contour these areas better. And we also are able to contour the areas that are important critical structures to minimize the radiation to those structures. So the data for treatment with radiosurgery for trigeminal neuralgia is great. Patients, again, outpatient comes in, gets treated for 20 minutes under a robot, goes home, and we're talking about 93% control rates, 85% at 12 months for something that is life changing. Patients who we treat, they have significant improvement and their lives are altered. They can go back to eating normally and things like that. So it's really amazing to be able to kind of target such a small little spot really non-invasively as on the outpatient basis. Even more exciting is, as patients get older, essential tremor, a little different from Parkinsonian tremor. Essential tremor is a tremor that occurs, when you're trying to act, and then, it's very common. Is very debilitating as you get older, and a lot of times people have medically intractable essential tremor. There's a lot of different treatment modalities, but the concept is that there's this little small spot in your brain, and this structure in the brain called the thalamus, and a specific nucleus in the thalamus called the ventral intermedius nucleus of the thalamus. Now, it's a little spot in the brain that with old imaging, definitely in 1971, we couldn't treat it. And honestly, I think back in 2000, the imaging wasn't detailed enough to pick up this small area that we need to treat. Basically, the concept is this area kind of has like a haywire, there's this normal circuitry goes a little haywire, and that's why patients have these bad tremors. And basically ablating this little small area with a very high dose of radiation has the potential of improving those tremors. Now, there's different ways to kind of ablate an area like this. In the past, they would kind of go and you could do surgery. You could try to ablate it with radio frequency ablation, kind of burn it. You put a catheter in and try to burn the spot. That's a surgery. There's a newer technology that is people are using that's more common that I'm not going to talk about, which is called focused ultrasound. But there's also the ability that via radiosurgery, you can ablate this little small spot. There's been some really good data behind this. So, with gamma, it's called thalamotomy. So you basically have a small little spot, about 5 millimeters in size, circumference that you need to treat. You give a really high dose to that spot. And in this paper here, patients were nearly 92% tremor-free after treatment. So, this is something that, again, outpatient, non-invasive, and, the risks are pretty low if you have appropriate planning. There's a lot of kind of structures that are important surrounding this. There's, something called internal capsule that's responsible for motor movement. So as long as you have precise treatment planning, like we talked about in terms of the Cyberknife, how good is your treatment plan? It's based on the detail of your imaging and the precision of the targeting. So this is something that's really, again, changed the way we treat, and this is a functional disorder that as our technology is getting better and better, it's a great treatment option for patients. And then here's kind of the future is as neuroscience has become more advanced in understanding concepts such as depression and obsessive compulsive disorder and eating disorders. So there's this whole field that people are looking at how can you ablate certain structures that over time we've been able to understand the circuitry and do ablating these structures lead to improvement in these psychiatric disorders. So this is a paper out of Virginia that they use what's called radiosurgery. In this case, they use gamma knife. There's a certain small, tiny area that is that if you treat, we call this an anterior capsulotomy. So I don't want to belabor the fact of the detail of the neuroanatomy, but this is known to be part of the circuitry an obsessive compulsive disorder. So if you can kind of basically burn this area and quiet it down, this article showed that that with patients with severe refractory obsessive compulsive disorder, they saw significant improvement in these, basically ablating these two little areas in the brain, what we call the anterior capsule. And you could see afterwards, we're talking about a couple millimeters in size, these lesions that they're made. And again, this is a frontier that continues to advance as people look more and more into treatment of neuropsychiatric disease. And again, as our technology improves, as our imaging improves, as the precision of these kind of non-invasive tasks improves, the morbidity or the potential risk with treating something like this goes way down. So then the potential of treating these psychiatric diseases with something that's non-invasive becomes more and more likely. So overall, that's kind of the frontier, and that shows kind of the level of precision and again the advances in technology that's allowed us to do this. So just kind of in summary, the goal was to kind of understand the concepts of stereotactic radiosurgery, the different treatment modalities we talked about. And I really kind of went in length about the Cyberknife, which is one modality that we use for radiosurgery, and that I use, on a weekly basis. And then, this concept that stereotactic radiosurgery is not just for brain tumors, but it's used for, a number of different things, including brain cancer, locally aggressive skull-based brain tumors like pituitary tumors, neurovascular pathologies more and more, arterial venous malformations, dural AV fistulas. It's changed the way we treat spinal tumors. Honestly, some people are looking at radiosurgery for the treatment of, chronic pain in the spine. And then, kind of the most exciting frontier is functional radiosurgery, which really has been, as we learn more and more about the brain, we learn about these kind of these pathways that kind of go haywire as we get older, or in psychiatric disease, and targeting specific parts of these pathways, now that we have the ability to be precise, can potentially lead to significant improvement in quality of life. So that's all I had. Thank you for listening, and I'm definitely happy to answer any questions. So I will switch to my screen, and again, thanks a lot for attending. I'm going to hand it over back to BFG to moderate. Again, thank you very much.
Thank you, Naveed. I think I learned a lot, and it also raised a number of questions, but we'll begin with the ones that came in during your talk. The first one is, I guess I should also remind everybody that before we turn to the Q&A portion of our program, I need to remind you, those of you who may have tuned in late, that your participation confirms your consent to be recorded and appear in any and online publications and rebroadcasts of this Propeller. So taking our first question, it's come in from longtime Propeller attendee, Joe Budelis, Johns Hopkins and Harvard alum. And his question is, what are the pros and cons of Cyberknife versus Proton approaches?
Yeah, so I kind of briefly touched on this. So proton radiosurgery has definitely the benefit of not having an exit dose because of this concept called a Bragg peak, where the dose kind of at a certain depth, we know that the dose basically stops and there's no exit dose. But protons, you can't put protons, in like the linear accelerator, the head of the Cyberknife robot. So they're not as conformal, the kind of the entrance dose is a little bit more difficult to get. But in general, for certain patient populations like pediatric patients who you really want to minimize the exit dose, we really do recommend a proton radiosurgery for that. But again, as technology improves and the ability to conform proton beams specifically, minimizing, kind of the entrance dose, then, proton beam technology has a significant advancement. The other negative behind protons is to have a to be able to do proton beam radiosurgery is much more expensive, compared to Cyberknife radiosurgery. So a lot of centers don't have it. I know there's been some efforts to kind of have, smaller proton radiosurgery centers. And I remember when, when I was at Mass General, they did a lot of proton radiosurgery, but some of the kind of offshoots of trying to make a cheaper proton radiosurgery, from my understanding, is they've had some difficulty with the technology when they try to make it cheaper. But in general, Cyberknife, proton beam, and gamma knife, for a lot of the things we talked about, they're pretty much equivalent. But for certain populations, like pediatrics, who we want to really minimize the exit dose, protons are probably better.
I was curious, in the pediatric populations, how young can you go?
Oh, they treat really young patients. I personally don't treat pediatric patients here, but unfortunately, bad pathology can happen at any age, and there's definitely benefit for treating especially kids with radiosurgery rather than conventional radiation, because as you're growing, radiation affects you much more than when you're older. Again, like we talked about initially, radiation affects growing, dividing cells, and kids have a lot more growing, dividing cells. So radiosurgery is extremely important for that population.
Can you do radiosurgery prenatally on fetuses?
That's a good question. I don't know, but that's a good question. I'm sure in the future they probably will.
As far as getting back to kids for just a minute, are there certain centers in the country that are particularly advanced and well known for really being in the vanguard for pediatric patients?
Again, so for pediatric patients, I really go to a center that does proton beam radiosurgery, just because the exit dose is negligible. So I think it's just very important, whatever center, if they're getting treated with radiosurgery, it's probably better for them to get proton beam. For children, for adults, it's pretty much a wash. They've done kind of comparisons; it's about the same.
You mentioned psychiatric disorders, and looking ahead, you mentioned OCD, that you could go to a particular place in the brain and disrupt the circuitry. Do you foresee it being used at some point for things like depression or addiction? Absolutely.
That research area is extremely active. So there are some places that they're actually doing treatments on humans, but I know of some colleagues who have monkey models of depression or monkey models of addiction, and they try to ablate certain areas of the brain, and they see how it affects, and it's a very kind of exciting field. And again, going back to kind of my first slide that we talked about, this is only we're only able to do this because the advancements in the detail and technology that we have in the imaging. So as you guys know, memory is so much cheaper and easier to store now, and processing speed is amazing. We have supercomputers in our pockets now. It just keeps getting just more advanced, and it's really exponential in how things have been growing. They've been combining these things with processing and understanding via AI. So we're just understanding so much more and more in terms of the circuitry. Radiosurgery comes in it is now we can ablate spots. If you tell us there's a certain spot in the brain that is causing this patient to have significant addiction, we could target that spot. And I think that's kind of the exciting part.
Are you able to tell us a few of the centers where leading work is being done on the depression and addiction treatment modalities?
I think a lot of the big centers are doing it. I'm one of my close friends and co-residents at Brown. He's specifically studying addiction and depression. And I have another colleague co-resident of mine who's looking at this at Dartmouth. But the basic concept is, once we have definitive targets that could potentially lead to a benefit, most centers that have the ability to do radiosurgery will start treating these. So go ahead.
Oh, no, please.
No, so here we've treated a few patients with essential tremor with radiosurgery. These are some patients who, had really bad tremors that were what we call medically intractable. And we ended up treating that small little nucleus in the thalamus known as the VIM, and they've had significant improvement. So, I think once we know more and more about, the kind of haywire circuitry and specific targets, we're gonna start treating those areas.
Do you think it might be useful potentially in treating PTSD?
Again, if people understand that specific circuitry, then it's a potential. So going back to my first slide, functional MRI. Remember, so functional MRI is where they're doing an MRI and looking at areas of hyperactivity in the brain, and there's that area of research where you can basically find out what areas are lighting up in the brain. Let's say someone is having a specific episode. Those areas have been able to kind of delineate, a potential target. And for instance, if that area is consistently being hyperexcitable, then you could treat that target, So that's kind of like the very kind of simplified concept of it, but that's, as our technology gets better, as our functional MRI gets better, you could really kind of pinpoint the problem area and then ablate those areas with radiosurgery or focused ultrasound or et cetera.
Well, it's very exciting to think about the prospect of better treatments. We have the next question is actually, it's embedded. There are probably 7 questions in this, and I'm going to just read the whole thing and let you sort out how you want to approach it.
Sure.
Okay. This person's interested in a lot of the technicalities, and that's Frank Rumor, one of our MIT attendees. He's interested in the following. Beam diameter, wavelength, is laser-like beam collimation achievable? Are electron beams ever used? Are targeting pellets implanted for motion tracking? Is the 4-centimeter tumor limit because of toxicity simply a matter of the larger mass of necrotic tissue that needs to be absorbed? And the last 2 parts are 2 or more intersecting beams ever used? And is SRS done with proton therapy?
Yes. So the last question, yes, proton beams are used for SRS. This is why, again, when we treat with stereotactic radiosurgery, it's a team approach. So there's a radiation oncologist, there's a physicist. We have 2 physicists here that go through every single plan. And I think, some of his questions, one of the physicists would definitely be able to kind of go through in detail. But kind of going back to collimation of the beam, that has really kind of advanced. The collimation, the smallest collimator we use right now is about 0.5 millimeters. There's talk about, there's talk about even making, smaller beams, and that's just an area that is I think with advanced technology will just continue to improve. And then in terms of kind of going back to this question about, the limitation of 4 centimeters for treatment of tumors, it's really as the tumor kind of dies internally and it becomes necrotic, it does continue to swell. A lot of times we are able to kind of take care of that swelling with steroids, which kind of minimize with the swelling, the vasogenic edema. But there's newer drugs out there. One is the anti-angiogenic drug known as Avastin. And it really kind of minimizes the radiation necrosis related edema. So there's a lot of approaches these days to treat, even larger tumors with the thought process that it's going to swell and we're going to minimize the swelling by giving these medications. So, I think it's definitely a field that people are actually looking to see how do we minimize that necrosis and such that we can even treat bigger and bigger tumors. And that's kind of advancing. I would say just in my own kind of, 15, 20 years of, learning about this, using it and seeing it advance, we're treating bigger and bigger tumors. and we're seeing less and less side effects as the technology's advanced. So I think a lot of that older data was with kind of when the technology, when the imaging wasn't as great, and now as our imaging and our planning has become better, I think those side effects we see much less.
Our next set of questions comes from Greg Dobbs, another longtime Propeller attendee, a Dartmouth and Princeton alum. And I'm going to break these questions up a little bit into categories. The first one has to do with developments, and you've touched on this, but I think he wants more information. Developments underway for the future of hardware and software. And if you could say some things about the cost of the equipment and whether most medical centers can afford it.
Yeah. So this is kind of one of the issues with kind of advances in technology, and you guys all kind of see this issue on a daily basis, right? You get a phone, and the phone works well, but because of advances in technology, there's another phone that's coming out that you have to pay $1,000 for, and it has like, a couple more features, it's faster, et cetera. So the problem with this type of technology, and I think why some of the advancement has been limited, even though there are things out there that are better than, for instance, what we have now, is the cost to hospital systems, for instance, for something like the Cyberknife costs about $2 million, okay? So if it's working well and it doesn't have much side effects, it's unlikely for the hospital to upgrade, and pay another couple $1 million for a new piece of hardware. For instance, with proton beam radiosurgery, again, if we had the best case scenario, you would try to use protons for all radiosurgery. Proton beam radiosurgery initially, the one at Mass General costs about $200 million. As they've tried to make it cheaper, there's kind of like question, knockoffs or et cetera that you could buy for $20-40 million. But again, the capital investment on something like this, when the current one is working so well, it's tough to really kind of get, hospital administrators and et cetera to kind of upgrade, upgrade the iPhone, upgrade the Cyberknife, upgrade, to, proton beam, because of it's working well right now. It's like you have a phone, it's working well, you don't need it, but why upgrade? But the technology is advanced. So honestly, to kind of answer your question, I think there's certain things, like there's something called the ZAP. It's like a new technology. It's faster than the Cyberknife. Actually, John Adler, who developed the Cyberknife, he has developed that technology. But the problem is, although it treats faster, supposedly it's more accurate, more precise, the cost is like $5 million. So hospitals, it's difficult for hospitals to buy into something like that when the cost is so expensive. So again, I think the advances in technology are already kind of improving, but I think the implementation, because of the cost and the fact that right now it's working pretty well, is the main issue. But just to kind of go back, software has been advanced, hardware has been advanced, but I think it's tough for a lot of hospital systems to upgrade their systems.
Well, I think you did a great job about explaining it from the hospital equipment perspective, but Greg has an additional question about cost, and this is from the patient perspective. Given all the specialists needed for planning and execution of treatment, what is the typical cost of a treatment, and is it fully covered by Medicare?
So that's a good question. It is fully covered by Medicare. So even something like as essential tremor now is covered by Medicare. In terms of specific costs, as you guys know, every hospital, every place, every private center, they all charge differently. I'm personally on salary at Capital, so I don't know how much they charge, but I know something as simple as like an MRI scan that you get for something, for planning for this. One place will charge, $500, another place will charge $3,000. So I don't want to sidestep the question, but in terms of specific costs, to the insurance plan, I'm not sure, but for most cases, all the things I talked to you about, treatment for vascular disease, treatment for tumors, treatment for trigeminal neuralgia, functional disease, it's all covered by most insurance companies. And what hospitals actually, and what the system in terms of overall system reducing healthcare costs, this is actually much less in terms of costs to surgery. So they've done head-to-head comparisons that, for instance, if I have a skull-based tumor and I have an admission to the hospital with a 2 to 3 day ICU stay where we do surgery on the patient, that costs sometimes almost triple the amount you get for an outpatient radiosurgery treatment. So, again, everything is relative, but relative to surgery, it costs less. So in terms of, looking at healthcare costs, and then, people have even looked at something I didn't mention is people are, looking at treatment for epilepsy. Some people have certain areas in their brain that are causing seizures because of epilepsy and they can't undergo surgery. You can actually treat those areas with radiosurgery by ablating them. And they've looked at the cost of long-term epilepsy treatment with medications versus treatment of refractory epilepsy with radiosurgery. And it's actually cost effective to the system. It's actually less cost in the system compared to, constant, treatment with medications. So overall, the cost of the healthcare system is potentially less in certain cases, but it's definitely covered. But each place will charge you different, and that's kind of one of the problems with healthcare in general. You could get an inpatient, you get Tylenol inpatient, they charge you $300, and you go buy it, outside the hospital, and it's a couple dollars. So I think that's something that is a general healthcare issue. But overall, for the most part, radiosurgery has great data behind it, and it's covered by most insurances.
Well, that is heartening to hear. Greg's last question, and I'm intrigued by this one. Have medical schools stepped up the specialized training needed to make the number of specialists needed available? They doing a good job with that?
Yeah, I mean, I think it's more of like a residency program. So there's more residency programs that are kind of training specialists in these types of fields. I think medical schools are slowly kind of developing these into their curriculum, because honestly, it is changing the way we treat patients. When I was in medical school, you had stage 4 cancer that went to the brain. It's associated with the 3-month survival. Jimmy Carter is a great example. I mean, the guy was 87, he's 11 years out, 10 years out. And so that concept of these newer technologies and these newer kind of systemic treatments really have been started to be implemented in medical schools.
Are you able to say which medical centers are really at the leading edge of training students?
That's tough. I'm a Harvard Med School alum. Of course, I'll say,
I expected that.
But I know, the main larger kind of medical schools are definitely training that. And this really comes, honestly, if the center has stereotactic radiosurgery, if there are physicians there that are on faculty that do this, they're aware of this and they're teaching it. Unfortunately, at centers that they don't have this type of technology and they really haven't, are not up to date with the data, unfortunately, they're not teaching it. And, I honestly, I see that sometimes, when I have, either a resident who will come through or, even another, attending who they're not even aware of this technology.
Is this technology available all over the world, or mostly just in Europe and Asia and here?
Yeah, I think, it's most of the kind of countries that are doing well, they have the ability to do this technology. There is a talk about, I know that a lot of these kind of older equipments, like when we upgrade the iPhones, when we upgrade the Cyberknives, a lot of those older technologies, they are trying to get out to, more countries that, don't have, the capacity to kind of pay for the newest and greatest. So it is slowly kind of trickling down to the less wealthy countries, but right now, in most countries, stereotactic radiosurgery is available.
The last question is one from me, and it's not about cancer per se. You and I have talked about this a little bit. I know of an instance of someone who was diagnosed with a glioblastoma, and the survival rate for that is not very much time typically. But this person was put on an experimental diet that medical school was doing, and she ended up living another 6 or 7 years with a pretty good quality of life up until the end. Could you comment on diets that some people are using to treat brain tumors?
Yeah, so diet and cancer is a really hot topic, and specifically for glioblastoma, people have looked at the ketogenic diet, and does that benefit patients in terms of outcome? And the bottom line is there's anecdotal cases like the one that you mentioned in regards to your friend, that people do see some benefit, but when they do kind of bigger, larger studies, and there's many studies going out around, the data is kind of mixed. So some patients have some improvements, some patients don't. So bottom line, there's not a definitive answer, but there has been a lot of research. And I think Josh Rabinowitz at Princeton is heading up the cancer diet. I forgot. It's a certain institute you guys are calling it now at Princeton.
It's the Ludwig Institute, and I do know of his work.
Yeah. So he, there's this concept, and I know Josh, and we've talked about this, that when a patient is getting chemotherapy or getting treatment, if they're on something like the ketogenic diet, the tumor cells have the inability to repair after chemotherapy treatment. So he's shown in mouse models for pancreatic cancer that if you put a mouse on a ketogenic diet before treatment and you treat it with chemotherapy, the mouse will die. If you treat the mouse and they're on a ketogenic diet while they're getting treatment, the DNA repair ability of those tumor cells is hindered because they're on a ketogenic diet, and those mice survive. And then again, the other group was like, if they treat the mice and they start the ketogenic diet after treatment, the mice still die. So the concept, the big concept is when you're on a diet like the ketogenic diet, the tumor cells have lessened ability to recover from things like chemotherapy or radiation, and that's the potential benefit from that. But big picture, it hasn't panned out. But there's multiple studies. We actually have a ketogenic diet GBM study here at Capitol, and it's just tough to enroll patients into the study because it's a tough diet. You already have a bad diagnosis of brain cancer, and patients want to eat, how they want to eat. So we've had one patient who we actually enrolled in the study, and anecdotally, he's 2 years out from the diagnosis, which is pretty good.
For those who don't know what a ketogenic diet is comprised of, could you just briefly describe it?
That's tough. We have a nutritionist on staff here who kind of tells us, but basically it's like no sugars, no carbs. It's like mostly protein. But I would, to be honest, it's something that I would never try. So I don't know the details of it, but we actually have a nutritionist in-house who monitors the patients, actually make sure they're developing ketones. But the concept is you really don't want glucose in the diet and fructose and those types of things. But that's not something I'm like an expert in, the diet, but it's something that so many people are studying, the concept of does changing your diet affect your response to cancer treatment.
Well, the patient that I referred to in my example when we chatted was told no pasta, no wine, no bread. And those are three things I never eat. So I hope I never have to be on that diet, but I guess it wouldn't be a problem. I see no further questions in the chat. And so I think I will extend a big propeller thank you to you for tonight's talk on major breakthroughs in managing neurologic disease. We also thank our attendees, an ever-growing audience of entrepreneurs, navigators, and the curious. Until we meet again next month, you can reach us by emailing propellers@princetonAAA.org. We're now planning and scheduling propeller programs for the year ahead. So please send us your ideas for topics and suggestions for speakers who, thanks to Zoom, can be anywhere in the world. And now, wherever you are in Asia, Oceania, Europe, Africa, or the Americas, it's time to bid farewell. Our next propeller flight is scheduled for Tuesday, April 12th, 2022, 7 p. Eastern US time. Please mark your calendars. Until we meet again, this is B.F. Graham on behalf of the Princeton Propellers, signing off and wishing you high spirits and happy landings.